Yeah, thank you so much. So where do I start? Let's see. I think firstly I want to thank the organizers and thank Nida so much for also reaching out. I think it's a real privilege to be here. I wanted to actually what was being spoken about this morning resonates a lot with me on both a research as well as a personal level, and I think it's important to also tie in, like why I'm doing this and to situate my work in my own personal story as well. So, for me, I was diagnosed with HIV 15 years ago. So I've been living with HIV for 15 years, and that was when I was 20 years old. And it was a result of sexualized drug use or chemsex, but also because of a lot of the internalized stigma around living with HIV. I only sought treatment about 2.5 years after I was diagnosed initially. And, I was also engaged in like a very deep cycle of like chemsex. And it ended when I was admitted into rehab when I was 24 years old. And I spent about a year and a half in Thailand in rehab because in Singapore, rehab means prison. So, I'm privileged enough not to go to prison in Singapore. But, I had the opportunity to do that in Thailand. And after coming out of it, I think we started to do more ground-up community work to try and support others in the same situation because, you just didn't find any resources for gay men, in this area back then. We had generic resources from, the Institute of Mental Health in Singapore or, mental health services, but, we just didn't identify with any of the support groups there, and I think you would see maybe from my slides later that we came from a particular perspective, but I think throughout my research and my work, both in the community and based on personal experience, we're starting to learn that there are many different angles we can take for addressing chemsex or sexualized drug use. And I want to apologize. So I use a combination of AI and my own I wouldn't say limited because I learned Chinese growing up. It's just that my command of the language is not very good. So, there might be some things that are maybe awkward phrasing or not so good phrasing. Please forgive me. So I think I'll focus on harm reduction for my talk today. I won't cover so much of this because other speakers have talked about the definition of chemsex. One thing that I will say is that in Asia, I think we still haven't really figured out a common definition. And I don't know whether we will ever have a common definition because it is so unique to different contexts. And one thing is that for Singapore we have certain combination of drugs, but for Hong Kong it might be slightly different based on drug supply chains, which differ from region to region. So being able to measure that across different regions is also problematic sometimes. I think I've seen some literature coming out of, let's say, I think Guangzhou, that talks about alcohol being part of chemsex or sexualized drug use. Technically, you could kind of label it as that, but we're not really talking about the same thing. So when we compare these things, it might be a little bit difficult. I think the purpose of this slide, and I'm going to breeze through some of them because I know we are also running short on time today, but this here shows that based on even just young key populations at risk of HIV, you're already seeing people start young, including myself, right? So at 18 to 25 years old in Singapore, we ran a cohort study. About 5% of people had already ever used crystal meth in that cohort. In Dhaka, Bangladesh, there's in a cohort of 18 to 24-year-olds, about 6.8% reported ever using meth. In New York, it's about 10%, and they reported engaging in sexualized drug use in the last 6 months. So you can see that I think for young key populations, this is an emerging issue of a potential concern. Even worse is that among non-MSM or non-gay populations like transgender women or sex workers who are at risk of the risk of HIV, other STIs associated with chemsex, we don't really know much about that. And the research that has been on trans women, for example, tends to be aggregated together with MSM. So we don't really have that much research focusing on some of these subpopulations that are also vulnerable due to intersectionality and so on. There was a qualitative synthesis, a review done by APCOM on sexualized drug use, including chemsex, and the motivations that they found, I guess, in this region for Asia don't differ too much from that in like the studies of the US and the UK or in Europe. These revolve around, say, enhanced sexual pleasure, freedom and confidence to explore sexual fantasies. And, I really like what Odile talked about in terms of the context that we are in, right? I think a lot of these are also a product of, a very stigmatized context that we have grown up in contexts where we are not allowed to be ourselves, where we want to find some form of liberation and emancipation. So I think that makes a lot of sense. And so, issues like pride and empowerment or even beauty and social power should be contextualized in some of these like narratives and contexts that we are growing up in. There are other issues of around using it as a social and sexual lubricant. There's some context where there's a certain community identity and culture attached to being in a chemsex community or sexualized drug use community. But a lot of the work that also I do focuses on using it as a coping mechanism. And I think I also heard terminology like small T trauma and big T trauma. And we can also use a trauma-informed perspective to address chemsex as well. So one thing I want to start from is this idea that when we talk about drugs and chemsex, I think the narrative has always been, we shouldn't talk about it. It's very taboo. Like it's entirely illegal, especially where I come from in Singapore, right? If you fly into Singapore on any plane, they'll remind you that there's a death penalty for drugs in Singapore. I think the death penalty applies to drug trafficking, but you don't need to prove that you're drug trafficking. It's you are a presumed trafficker by a large amount, having an amount of drugs above a certain threshold. And that is also problematic because I know people who engage in chemsex who hoard drugs because they are so afraid of, like running out of drugs as well. So, I think these are some issues that we deal with. So coming from this idea of the narrative on the war on drugs, what has this produced in terms of a lot of our public health research for chemsex? I think scholars have, especially critical drug scholars, have talked about this idea of the rush to risk when it comes to public health. So we tend to think about the risk first when we're in public health. And they talk about how, public health has made important contributions to establishing the link between, for example, meth use and sexual risk-taking, but the precise nature of this relationship is often not well defined. We always immediately think of chemsex and risk, chemsex and risk. This creates space for ungrounded assumptions about methamphetamine use to take hold. I think there are other issues that have been raised also. So we also need to acknowledge that there's non-problematic, so-called non-problematic use of substances. That there's some chemsex that can actually be productive and also to what people think like fun and pleasurable. There's also, we need to reframe the role of drugs as well in sexual behaviors, because if we solely blame drugs for disinhibition and other forms of risk-related sexual behaviors, it actually limits our ways that we understand how to address chemsex or sexualized drug use, by just focusing on that only. And in a related way, we need to move beyond biomedical forms of understanding. The reasons why people use drugs have certain social, political, historical reasons as well. These are unique to each context. And if we want to address the risks associated with chemsex, we need to better understand some of these, the context as well. And so this is something that I've come up with, I guess, as sort of like a framework to think through, what harm reduction might look like based on some of the different narratives of chemsex out there. And this is actually more informed by, what I hope we can approach chemsex as a person-centered kind of approach, meeting people where they're at. And there are different journeys that structure, how we should approach chemsex and addressing harms related to chemsex. One of them is this idea of the chemsex or sexualized drug use journey. I'll share a little bit more. The second one is definitely the context in which sexualized drug use takes place, because how it takes place and where determines what kind of resources you have to address risks for HIV and other STIs, for example. And the third one would be the personal life course. Chemsex journey is just how people started and where they are at in that journey. But we need to think about trauma. We need to think about life experiences. These are also things that people might inform why people use drugs as a coping mechanism, for example. So when we think about the journey, the chemsex journey, actually what we have seen, because I also help run a community, a charity in Singapore where we provide substance use recovery services, and we've seen people come in. Initially what we did was everyone is an addict, because I came from the 12-step group kind of modality, so like when we started our support groups, we said every all use is problematic, and everyone who comes in, you can call yourself an addict. And people didn't, a lot of people were turned away, from that because they didn't identify with that. And if we look at the literature also, and we see that, this idea of problematic versus non-problematic in itself tends to be a little bit problematic because who defines it, and how do people define it? But I think the common ground beneath it is that if we want it to be person-centered, we have to empower people with the knowledge, skills, the social support, and the resources for them to be able to say what is problematic and not problematic. And I think Dr. Lee in the previous panel talked about some people might not be ready to access services, and this is it's kind of related to that as well. This is from Canada, they have a spectrum of drug use that they also promote in their health systems. There are forms of drug use that, there's non-use, there's certain drugs or psychoactive substances that involve beneficial use. But, we think, if we think along the lines of this spectrum, on the other end, it's substance use disorder or addiction, and that's where a lot of our services tend to be focused on. So this is, I just wanted to maybe share this for now. I'll come back to it later. And if we look at this whole problematic versus non-problematic use, there are studies out there that try to research or review the proportion of people who have problematic versus non-problematic use of substances. One caveat here is that these are general population statistics. It might differ from subpopulation to subpopulations, especially for key populations. But what the story that this tells you is that, not all drug use is problematic. And I think being able to identify that will help you reach people where they're at. There are studies also that look at chemsex journeys. So what kind of journeys do people take when they start having chemsex? This idea that you start off with loneliness and emptiness, and then you search for connection, and then after that it becomes problematic, and then the severe health impact. This is actually the kind of journeys that we do see at the center as well. And it reflects a form of coping mechanism and all that. But also, this tends to maybe overemphasize that one end of the spectrum, right? Where it's substance use disorder, dependence issues, and all that. But so the authors here also say that we shouldn't take this as what will always happen. It does not always evolve this way, but it's also helpful to see where people are at in this journey, so we can make sure that our harm reduction interventions are at the right place. And what kind of themes do we talk about? This might be familiar to a lot of people doing programmatic or social work, or psychological interventions as well. The trans-theoretical model of behavior change, and this is the where people are at. If I'm making a change, is it pre-contemplation? Am I still thinking about it? Am I even before thinking about it? And this is where maybe certain kinds of interventions, like motivational interviewing, and these kinds of interventions that promote or improve motivations for change might be helpful. So if you have a well-made intervention in the community that's fully, evidence-based, but you're not meeting people where they're at, it's also not going to work. Okay, so now that's basically the chemsex journey, right? These are all the different considerations that you need to take. Now let's look at the context in which chemsex takes place to make sure that we are reducing harms in that context. So this is a study, I think, published by colleagues in Taiwan and Australia in the Lancet HIV, which looks at harm reduction for chemsex. And they break it down to a very event-based approach. And basically they're saying that when you have chemsex, there are these risks that you need to take care of. One of them is HIV, one of them is the sexual risk, and one of them is related to drugs. And there are all these different things that you can do, to address these things individually, but also these are the things that you need to think about to address, all these reduce harms in these contexts holistically as well. So I think it's actually quite helpful when you're thinking about harm reduction interventions, for people who are engaging in chemsex, to help them make sure that they reduce the harms, all these types of harms that are typically associated with it. One thing about context also is that we've looked at a lot of qualitative research as well, and we noticed that the way that chemsex takes place from one place to another is quite different. And, I think being able to know what are the different rituals, how do people go online, what kind of words do they use, like how do people meet, where do people meet, what happens, in Singapore when people have like camp fun or camp sex, like there's also a bit of like card games playing and, like a lot of these like social things, right, which are also opportunities to inject certain kinds of, harm reduction, like messaging, we haven't been so creative yet, but I think those are all important, right? Because it tells you a little bit more about what people value in these spaces as well, and what access to, harm reduction resources that they have. And the third one, looking at life histories, this is some research that we've done at the Greenhouse, which is the community group that I'm with. And we looked at how trauma underpins a lot of chemsex in our clients as well. So like basically there's sexualized drug use or chemsex, but among our clients we note that a lot of this is underpinned by psychosocial distress, sexual shame around their sexual orientation, social anxiety, low self-esteem, loneliness, and then we wanted to dig further, right? Why are our clients facing these issues in such large numbers, huge numbers of like reported forms of like adverse childhood experiences and stuff. And then we realized that, a lot of precipitants here are underpinned by forms of trauma, especially small t trauma. So folks who have undergone racism, HIV-related stigma, sexual violence, neglect, internalized homophobia and all that, tend to present with a lot more of these precipitants. And when we look at the context that we are in, actually in Singapore, people grew up in this context where, being gay was criminal, right? I think it was only 2 years ago that we repealed Section 377A. It was actually just like 1 month ago we now don't require people with an undetectable viral load to disclose their HIV status, which is a great advancement in our legal policies. So there has been a lot of discrimination and stigma associated with being gay, living HIV and all that. And these all underpin all these things, which then weighs down on the idea of sexualized drug use or drug dependence. So I guess to sum up that harm reduction part, like if we're thinking about harm reduction and we look at all these different complex issues around chemsex, I think understanding where they are at in their journey of chemsex, understanding if it's dependence or substance use disorder, like at which stage of change that they are at, what kind of life histories do they have, what kind of traumas do they have, and what are the different cultural practices associated with chemsex. If we are able to understand all these things holistically, I think we are able to better develop harm reduction interventions for people where they are at. And this is something that it's sort of like me putting together all these things that we have presented so far. So, if we wanted to make it maybe a little bit more simplified, we could think about, where people are at in terms of their type of use. There's people who don't use, people who use and they feel that it's been beneficial to them. It helps them connect. It helps them gain more pleasure. There are people who use it, but they expose themselves to risks. There are people who use it and they're dependent on it. I think the approach should be different. And, like if we think about people who don't use it, I think it's still important to reach out to them, right? Because, a survey that we did in Singapore, basically 50% of our MSM, or the gay men in Singapore, have ever tried so-called illicit substances. So it's very safe to say that 1 in 2 people will encounter substances in their life. It's just that what kind of context you're going to be in. So having early education programs for young key populations is important because we have to really grapple with this idea that you will encounter drugs. We cannot not talk about it or until after you've encountered it. So what kind of early education programs do we need? And those who are in that space of, I'm kind of using it like once a year. I go to these circuit parties, like in Thailand or Bangkok, engage in a little bit of chem fun, chem sex. It's been very fun for me. I use PrEP, I use, like DoxyPEP, whatever, very empowered people. I think it's also safe to assume that some of them might run into issues time to time. And so being able to still have harm reduction services for them is still important, like the one that we saw in the Lancet HIV Venn diagram, right? Reminding people, don't mix this with that. I've got some examples in the next couple of slides. But when you start to see higher levels of risk associated with use, I think that's where we need to maybe have more interventions. And I'm a bit more familiar with those who are on the right end of the spectrum because that's where our services are. And we do like peer support systems. We are more community-based. We're an anonymous clinic. So I wouldn't call it a clinic. We're an anonymous service, with peer navigators, peer supporters, counselors involved. And so that's where we try and customize care because we really need to get people involved with psychiatrists, psychologists, long-term support groups. We link people up with support groups like Smart Recovery, Narcotics Anonymous, things like that. So I think that's where we need a little bit more intensive programs. So just some examples, I'll breeze through this. So like early education programs, to focus on, what are these common drugs you might encounter, where to find resources if you need them, and also maybe teaching people how to support others. When we give talks like that, a lot of people ask during the Q&A, if I know someone who's engaging in chemsex, like how do I talk to that person? These are all things that we can equip people with. I've seen this being posted, so I think our local NGO posted this once, right before like the circuit party season, and they got into a little bit of trouble around it. But this is like a chart that shows you what you should not mix. GHB should not be mixed with alcohol, and all these things. And I think it's in response to the fact that on average every year, we hear like maybe one person dying, from just mixing the wrong things, right? So I think that's an important thing to save lives. Less in Asia, we actually see. So this is the imagination when you think about harm reduction, right? We often think that harm reduction involves like safe injecting spaces and all that, but it doesn't have to be. In Asia, where it's still a lot more punitive context, this is something that we might encounter less. But I've seen some of these interventions in the UK where they use like Grindr, where they know people are they're hooking up, with like ChemFun or ChemSex, and then they provide information there. That's something that you could see as venue-based intervention as well, because we're just not only looking at in-person venues, but online venues too. These are some brief interventions. I won't go into too much detail, but like if you are in a place where you are more likely to see someone with a heightened risk or heightened chance of experiencing harm, in a PrEP clinic, for example, you might be able to have some brief interventions based on cognitive behavioral therapy, motivational interviewing. They've done this for alcohol-related disorders. I haven't seen one for like chemsex though, so definitely an area to do some interventions in. There's also customized care, which I talked about, which we kind of do as peer navigators in the community. So we make sure that, okay, if you come in and do intake, first we are going to make sure that your HIV STI testing is done, link you up with someone who can provide PrEP or PEP. If you need like medical advice, we can actually bring you to a psychiatrist. We don't actually provide those services, but we have a 6-month peer supporter that follows someone through this whole like process for 6 months as sort of like a para-counselor. And this is the community group that we have. I won't go into details, but you can find us online, the Greenhouse. And these are all our volunteers and our board. So we basically, our program is based on counseling, peer support, 6 months peer support, 16 free sessions of counseling. We do like horticulture therapy and all that. And it's all entirely free for people because we also, the counselors are also free to us because we are a training site for them. So we partner with schools to do practicum training. We just pay our volunteer clinical supervisor. But yeah, if you want to find out more, you can talk to me during the break or during the Q&A. We also have a guide for how to deal with law enforcement because I think the law enforcement in Singapore is not very friendly. And harm reduction to me is always about, the law can also harm you. So how do you stay safe from the law? It's quite ironic, but it's the fact. Because if you get incarcerated, I constantly have people I know in jail, and I think it's quite tragic, especially when a lot of them are facing issues of homophobia and all that, right? And if you are caught consuming, it's like 1 year in prison in Singapore, and their life basically just crumbles after that. So you're doing more harm than good, right? So I think this is a guide that we decided to do for people on how to deal with law enforcement in different situations. So I won't go into my key takeaway messages, but I'm happy to share the slides around if you want a copy of the slides. But yeah, I think that's all I have for today. Thank you.